welcome to OsteoBites. Thanks so much for joining us today. We'll give everyone just a few seconds to get comfortable in our virtual room. I appreciate your taking the time to spend an hour with us today. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Jennifer Mack from Dana-Farber Cancer Institute, Boston Children's, and Harvard Medical School. And she's also part of the PE-CGS Network, which stands for Participant Engagement in Cancer Genome Sequencing, Count Me In Research Center team. And she'll be discussing reasons that patients may or may not want to participate in research, ways to engage patients in designing and carrying out trials, and Count Me In is one model for engaging patients. Thanks so much, Dr. Mack, for joining us on OsteoBites today. We are thrilled to have you. And thank you also to our panelists, Max and Camille, for joining us today. A little bit more about our guests. Dr. Mack received her medical degree from Harvard Medical School in 1998, and she subsequently completed her residency in pediatrics and her fellowship in Pediatric Hematology Oncology at Boston Children's Hospital and the Dana-Farber Cancer Institute in Boston, Massachusetts. And in 2005, Dr. Mack received a master's degree in public health from the Harvard School of Public Health. She's an attending physician at Dana-Farber Cancer Institute and Boston Children's Hospital, director of the Center for Outcomes and Policy Research at Dana-Farber, associate chief of the Division of Population Sciences at Dana-Farber, associate chief for the Pediatric Oncology Population Sciences at Dana-Farber, Boston Children's, and faculty vice president for the Office for Faculty Development, Professionalism, and Inclusion at Dana-Farber. She's also an associate professor of pediatrics at Harvard Medical School, and her research interests are in parent-clinician and patient-clinician communication, healthcare equity, and quality and palliative care. And Dr. Mack, given all the hats that you wear, we are very grateful for you spending an hour with us today. Just a couple of announcements before we get started. For any clinicians and researchers, our next virtual tumor review board for osteosarcoma, which we call TURBO, is on Wednesday, March 20th at 5 p.m. Eastern. And if you have a case to present or you're just interested in attending, just email me at christina@mibagents.org, and I will put that in the chat. And registration is open for our annual Factor Osteosarcoma Conference, which will be June 20th to 22nd. In Cleveland this year, and it's really unique in that it brings together everyone in our community. It's kind of like a medical conference like no other. We have clinicians and researchers, but we also have patients, caregivers, advocates, industry, and it's a really amazing time for collaboration and connection. And if you're listening to this webinar, then you belong there. And Max, Camille, I think you guys are going to be there this year, which is fantastic. And some of the scientific panels that we're going to have this year include how AI will impact clinical practice and research, targeting metastasis drivers, overcoming drug resistance, key pathways in osteosarcoma treatments, local control, creating an osteosarcoma atlas, preclinical models, immunotherapy approaches, clinical trials, and backed by popular demand, our patient panel. So if you are interested in getting feedback from patients, this is a great place to do it. Our patient panel is kind of like an open Q&A with osteosarcoma patients, many of which are AYA patients. And also Arian Siegel-Bote, who's the project manager on the Count Me In osteosarcoma project, is actually going to be there presenting on the clinical trials panel. So if you want to learn more about Count Me In, that's also a great place to do it. Registration is open. It's $335 per person, and it's free for osteo warriors ages 8 to 22 because we have an Osteo Warrior HQ, which is a fantastic place for all our osteo warriors to hang and connect. So since the topic today is about engaging patients in research, it's great that we have two patient panelists joining us today. So let's meet our panelists, Camille and Max. Camille, would you mind introducing yourself?
Yeah, of course. Hi, everyone. My name is Camille Wall. I am 21 years old from Boston, Massachusetts. I am currently the president of MIB's Junior Advisory Board for 2024, and I'm also the founder and a co-host of Osteo, MIB's AYA podcast. I was diagnosed with osteosarcoma in January of 2013, and since then I've relapsed 8 times, and I've also been a patient on several clinical trials, and I'm happy to be here today, and I will pass it off to Max.
Hi, Max. I'm 19 years old. I was diagnosed with osteosarcoma in 2015, and now I'm almost 8 years NED. With MIB, this year I'm the vice president of the JV, and I'm also involved with ambassador agents. I'll hand it over to Dr. Mack now.
Great, thank you all so much. It's good to be here with everybody, and I'm just going to share my slides. Okay, so as Christina mentioned, I want to talk about patient perspectives on participating in research and clinical trials, and I'm here for any questions as I go. So. Let's see. So what do I want to do today? I want to help you all think about patient perspectives on research participation, think about the best ways to engage patients in research, and talk about Count Me In, which is one model for engaging patients in research. And so I think we know this, but cancer research beginning in the laboratory and going all the way to the patients is the main factor that's responsible for improvements in outcomes for patients. Research on the biology of cancers helps to identify the right directions for treatments, and that kind of research includes genetic and genomic research in tumors, looking at their genetic material. And then cancer clinical trials are treatment trials, and they're designed to improve things like survival or quality of life or other things that are important to patients. And this is really the main way that we move the field forward for future generations, and that we've gotten as far as we have to date. But it's important to remember that not everybody wants to participate in research, and they have different reasons for that. We know that adolescents and young adults participate in clinical trials at lower rates than children. And we also know there are certain populations across the age range that are underrepresented in trials. And that includes racial and ethnic minorities, people who live in rural areas, and people with fewer socioeconomic resources. There are lots of reasons why people may not want to participate in research or trials. And one of the ones that I think about is research availability. Is there actually an available study for the patient? For osteosarcoma in particular, we know that for newly diagnosed patients, sometimes there's a trial and sometimes there's not, right? And so that's kind of an obvious barrier to trial participation, but sometimes we just don't have trials available, especially for these rare diseases. And then there are questions of access. So when I think about access, I think about, can you realistically get to the place where research is being offered? Camille lives in Boston, right? So she lives near a big cancer center. But what about people who live in North Dakota? Is it really that easy to get to a clinical trial center? So it's hard for patients who live in rural areas or outside of big cities. And also, when you're first diagnosed, especially if you're a young person, the first thing on your mind probably isn't, where can I get on a trial? Where do I have to go? It's probably all the other million things, that you're thinking about when you're faced with a new cancer diagnosis around, what does this mean for me? How's this going to affect my life? How am I going to get better? How is this going to interrupt everything that's going on with me? And then for adolescents and young adults, there are often, also factors related to your family that may make it hard to uproot and go to a new place for treatment. You may be living at home with your parents. You may be a young adult with kids of your own. And those kinds of factors really play into what people feel like they can do. And then there are issues around communication from oncologists. Sometimes there's a trial that's available, but the oncologist doesn't necessarily offer it. And, that's partly because it does take time for clinicians. And then it's not just the clinician that has to do it, but there's a whole back room of people who do a lot of the logistics around getting people on trials. And so sometimes the kind of support that's needed to make this happen is better at some institutions than others, and it may not happen. And then sometimes oncologists kind of make a judgment about whether they think a patient might want a trial or not. You might think, well, why don't they just ask? And I think that that's a good thing. That's better. But I think sometimes people kind of get a sense that someone may not want a trial and they may not decide not to offer it. And then, on the patient end, the way the oncologist describes it makes a big difference in how you might feel about it. So, how is it explained? What kind of language is used? How understandable is it with all these complexities in a trial? And sorry, I'm just getting over a cold. I have some tea here though, so I'll use it as needed. But what does the oncologist think about the trial? And is that conveyed to the patient? Are they excited about the trial? Or are they not excited about the trial? And you can imagine if you're in the patient's seat, that could make a big difference about how you feel about it yourself, because that's the person you trust, hopefully. And then there's the patient, right? So how does the patient view research? And, people have different levels of trust in the medical care system and in research itself. And historically, there's this difficult history around medical research in the United States and elsewhere, where some populations haven't been treated fairly or justly in research. And people remember that, that there is this history of experimentation on people who are vulnerable. And there has been a lack of really informing people about research. And, now we have very clear standards around this to make research safe and fair and right for patients. But still, people remember this. And especially for minoritized populations who have experienced structural racism, they may not feel this innate trust around trials that might allow them at such a tough time in their life to sign up. Then there are these things like randomization. Think about how it feels when you're first diagnosed and someone says to you, well, we have two treatments, but you don't get to pick. We're going to flip a coin. And, that doesn't always feel good, right? It feels like, well, just give me the good one, And so I think that even though we know this is important scientifically, it doesn't feel great for patients always to have that. Research is complicated. You may be overwhelmed at diagnosis, and and then people are throwing out all these complicated terms and concepts. There may be financial barriers. Sometimes when you're in a trial, you have more visits, more blood draws, more scans. And even if you may not have to pay for those blood draws and scans, you might have to pay for parking, or for gas or miss a day of work. And that's a big deal. And so, all of these things can make people question whether a clinical trial is the right thing for them. And so even if in theory they might like the idea of being in a trial, it might stand in the way. But at the same time, it's also important to know that a lot of patients do want to participate, and the kinds of motivations that we see, patients may want the chance of accessing a new treatment. They may want an option that's not available off a trial. They may hope that it will help them. And importantly, they may want to help future patients. I told you at the beginning that everything we know about how to treat people now is because of trials in the past. And people may want to pay that forward, to people who will be diagnosed 10 years, 20 years from now. Excuse me. And then sometimes it's a way to feel empowered in a time when you feel like you have no power at all. So, one question is, well, what are we trying to achieve here? When it comes to patient participation in research, are we trying to get people to enroll? Are we trying to not get them to enroll? What's the goal? And what I would say the goal is for patients to get to do what they want, for us to reduce barriers to access to research, which might be geographic, like where trials take place, financial and logistical barriers, to make sure that research is offered, and then to help patients make the best decisions for themselves, whatever those decisions are. And in addition, we have to think about equity. We have to make sure that everybody has the same opportunities for access and support, not only because that's the right thing, but also make sure that the results actually represent a broad population and has enhanced validity. What if, for example, the Hispanic population has some differences in their tumors that make them respond differently to treatments? If we don't include them in trials, then we don't learn that. And then we're not serving the whole population. We're serving the non-Hispanic population. So we really have to think about equity as a goal of everything we do. So how do we get there? And it probably isn't just one thing, right? Because I just told you about the cost of parking and how the oncologist talks about things and where trials are. So there's probably a lot of different interventions that are needed. But one path that's important is engaging patients in research from the beginning, getting their thoughts about how we should do things to do our best. So when I talk about patient engagement in research, I'm not just talking about participating in trials. I'm talking about being part of the process. And so, this means that researchers learn from patients about how they should do research, and patients get to be engaged, empowered, and respected throughout the process. And so there are certain principles that we think of here. First, we've got to be inclusive. We can't just only choose people who are at the big cancer centers or who are college educated, or, we have to be really broadly inclusive of all kinds of people. We also have to have a respectful collaboration. Patients and researchers both need to be an important part of the process, both valued. And this process values the experience of patients because patients know things that researchers don't. It has to be informed and co-directed by patients. And it promotes timely sharing of research findings as part of this process of engagement. And so it's really considered bidirectional. And there's kind of this power sharing, right? Patients have the same kind of voice that researchers do. So one question that we ask ourselves is, well, who are the right stakeholders? When I say stakeholders, I mean, who are the right people to involve in research? Who are the people who care about this? So, who has an interest in the work? It might be patients, it might be family members, it might be community members, it might be religious leaders or cultural leaders. We have to ask ourselves, is diversity an important goal? Is including a diverse population important for the research questions? And are there populations who have a special interest in the research and how it's carried out? One example there is for American Indians, there are often special issues around sharing samples of tissue or sharing samples of blood, because there are, cultural practices around the integrity of the body. And so, when we develop practices that involve sharing of tissue, we have to think about those cultural practices so that we can be inclusive. So that might be one example. And then there's the question of how should engagement work? So, we have to work out what are the communication processes between researchers and patients. What if they have different opinions? How do we figure that out? How do we navigate that? How is power shared? And what defines optimal engagement so that we can actually measure it? Because we want to know that we're doing a good job of engaging people. So those might be things like their feelings of empowerment, trust, and being respected and valued. And then there's this question about results. What's the process for engaging patients in return of results? How do we return results to the community? When do we do that? How do stakeholder views inform the type of information that's returned? And are there any harms to returning information? Those are all things we can work through with patients. Maybe later when we have discussion, I'd be interested if Camille or Max has ever learned the results of any studies that they've participated in, because I think that's one of the questions we have to consider is how do we actually share those findings when you've been part of a study? We can come back to that. Okay, so now I'm going to tell you about Count Me In, and that's partly because I'm part of Count Me In, but partly because I think it's just an example, right? This is just one way that we can think about partnering with patients. So Count Me In is a nonprofit research initiative of a place called the Broad Institute, and the Broad Institute is really interested in genetic and genomic information about cancers and other types of tissue. But Count Me In engages with patients and enables them to accelerate research by sharing their samples, their clinical information, and their voices. And so the goal is to generate publicly available information. So that's the other thing is it doesn't just sit in an academic center. It's available to everybody because we want to maximize discovery. And it's focused on rare cancers. To help accelerate discovery and develop new treatment strategies. And enrollment and consent are all done digitally. You can see at the right there is an example of what information looks like on the website. And so one of the principles is engaging with patients and communities. The idea is to listen to communities we serve, act on the feedback, connect with patients and their loved ones, work with trusted advocacy and community-based organizations, and remain available for feedback. So, I already mentioned that not everybody wants to participate in trials. Well, it turns out only about 5% of patients in the US are enrolled in clinical trials, and 85% are treated in community settings. And because of that, a lot of the work on tumor samples is done in academic centers, usually in cities. And so most of the tumor samples across the US are not available for study. So Count Me In was founded based on the idea that, okay, we've got all these new things. We've got social media, we've got websites, we've got, new ways to connect. Let's try to allow patients to directly engage in research by, working with us. And that way we can help ensure that findings apply to everyone. And so this is a timeline of different projects that Count Me In has taken on. So in October 2015, there was a project for people with metastatic breast cancer. 2017, angiosarcoma, a rare sarcoma. 2018, metastatic prostate cancer. Again in 2018, esophageal and stomach cancer. 2019, brain tumors. The osteosarcoma project launched in February 2020. And then in 2021, there was a launch of Count Me In for all cancers. So anyone now can register with Count Me In. And then it was September 2022 when we launched the project that we're doing now, which is the osteosarcoma and leiomyosarcoma projects. So many people had already enrolled in 2020 in the osteosarcoma project, and those patients were carried forward to the current project. But this main project has started in 2022. And you can see these little dots all represent people across the US who have joined these different studies through Count Me In. So on the left, it's the Metastatic Breast Cancer Project. And on the right, it's the Angiosarcoma Project, which is a much more rare tumor. So you don't see as many dots. But when you think about bringing together a group of people with a rare tumor, there's so much you can accomplish. There are different ways that Count Me In tries to engage patients. There's a lot of social media engagement, Facebook, interactive discussion polls, live chats, and webinars. There are focus groups that allow us to do a deeper dive with patients, advocacy organizations and patient advocates, events and conferences, and general community engagement whenever we can. And these are some of the things we've learned. So first of all, it's important to have consistent messaging. And we have to get the frequency of communication right. It can't be too much, but it can't be too little. You don't want to hear from us every day, but you also don't want to hear from us never. We have to work with patients to understand what is that right frequency? What is the right kind of information? What do you actually want to hear? We have different vehicles for communication. Some people really like social media, but some would rather get something in the mail or see you in person. When it comes to different languages, it's not just about translation. It's about understanding what's important within a community. How are things discussed? What are the important concerns within a community? And how can those be incorporated into the language and materials? That engagement should be continuous through the life cycle of a project. It shouldn't just be one time at the beginning or one time at the end. And that there should be work to develop partnerships with advocacy and community partners. And so when we think about the osteosarcoma and leiomyosarcoma projects, these are both very rare sarcomas. There are about 2,000 or fewer cases per year in the US. And, we're still not where we want to be in terms of curing people. And so one of the ideas is that if we understood more about the genomic landscape, the genetic material in tumors, we may be able to make progress. So we feel there's this urgent need to create a large shared database of clinical and genomic data in both diseases. But this has been hard because these are so rare. And some centers may only see a handful of patients with these diseases. So the goal is to engage patients across the US and Canada to create a large publicly available database of clinical, genomic, molecular, and patient-reported data. Here's the osteosarcoma project page, and if you go to the page, at the end, I'll show you the links again. You can watch videos about this. And then again, here are some of the life cycles. So we keep working over time with advocacy partners. We have different social media campaigns and toolkits, and then grassroots engagement. These are, again, some of the kinds of materials that we provide and that we post through social media. Here are some of the cards. One of the pieces of feedback we got is from patients is, sure, I can see it on Facebook and I might think one thing, but if my doctor tells me it's a good idea to enroll, I'm going to feel differently. That's going to be really helpful for me. So we have cards that we give to physicians and other practitioners that they can give out to their patients. We have Spanish language materials and also videos. And we have an advisory group of Hispanic, Latino patients to help us with this. And so when we ask patients how they've heard about us, this is for osteosarcoma, you can see there's all these different ways. Facebook is by far the biggest group. It's that darker green bar at the bottom on the social media tab. But lots of people have heard of us through advocacy groups, through their doctors, through word of mouth and other ways. And when we look at the racial and ethnic breakdown of the people who've enrolled so far, you can see by far the largest group is still white, about 75% of our sample. And so there's a lot of work going on to try to diversify our sample. And that's why we're developing, for example, the Spanish language materials and working with advocacy groups that may be appropriate to the Latino population and other work to try to engage a more diverse population. This is sex assigned at birth. For leiomyosarcoma, there are uterine leiomyosarcomas that only affect women, and so you can see it's disproportionately female. But for osteosarcoma, it's more evenly split, a little bit of female predominance. This is the age at diagnosis, and yellow is osteosarcoma. So you can see the biggest group here, not surprisingly, for osteosarcoma is people who are diagnosed between the ages of 10 and 19, like I think Camille and Max, from listening to your stories. And then for leiomyosarcoma, you get a peak more in the 40s and 50s. This is for leiomyosarcoma, these are all the different institutions where participants received care. And that's 215 institutions for leiomyosarcoma. And these are the states where we've had participants for leiomyosarcoma. This is for osteosarcoma. These are 74 institutions for 74 participants, partly because some patients got care at more than one place. And then this is the map for osteosarcoma. So you can see there's a big white space that we need to fill out. We've also worked with patients. I mentioned you've got to figure out how to give results back to patients, right? How do you do that? And so we've had feedback sessions with patients and with family members. And here's the kind of stuff they told us. Well, make sure you create appropriate expectations around when they're going to get the results and what the results are going to look like. And keep in mind, not everybody wants them. And maybe not everybody wants everything. So you have to give patients a chance to opt out. And then, think about what kind of resources people might need to understand results when they come back. Because understand this is outside of like a visit with an oncologist, right? So normally when you go get your results, you have a visit with your doctor and they explain those results with you and you have questions. If you have questions, there's back and forth. But this is different because this is straight to you. And so we have to create opportunity for people to ask questions and get the information they need when those results come back. We also reframed return of results, because this is research, to talking about what we are learning or what we've learned. Because we also just want to be clear that some of this is in evolution. We're trying to discover new things. And so we're also learning what it means. And we want to be as transparent as possible about that. It's a little different from getting your CBC and knowing what your white count is, right? So we want to be very clear about that. And so this is some of the kind of information that we give patients about their genetic changes in their tumor. And we explain to them that we're sharing with them some of what we found, and that those genetic changes help us learn more about how osteosarcoma develops and grows. This is a dashboard that we use for patients. So it helps them to understand where things are in the process, because the other thing we learned from patients is they don't want to just send stuff to us and then it's just a giant black box. They want to know where things are. And I get that because, it's like when you go to a restaurant and you have no idea how long you're going to have to wait for your table. It's way more irritating than if they tell you it's going to be 15 minutes, And so this is just a way for them to understand what's happening. And then here we give them a chance to opt out. Yes, I want to receive information, or no, I don't. And then here I'll just summarize some of the successes and challenges. So, one thing that's been great about this project so far is that we have really strong accrual rates. Enrollment's pretty widely distributed, some areas where we could do better. And there's a lot of physician engagement. A lot of the doctors who know you also know us, and they're interested in this project. We have more and more growth with advocates and a lot of engagement. And I think, our work to improve our Spanish translation and Spanish materials has been really nice for us. We're happy about that. But there are still challenges, and I already mentioned that white participants are about 75% of our sample, and so that's an important place to grow and expand diversity. Each time we need to make a change for the website or something, add new materials, even add videos and post things, there tends to be a fair amount of technical work, and there are a lot of people who need to do that. So it's not always as nimble as we hope. There is some attrition between enrolling and consent, meaning that like people might sign up, but then we may not get their medical records or we may not get their tumor sample. And that's because life happens, and it's not always easy to do all the steps. And we don't always have success in getting all the records and everything else. And then, we're just starting to return results now. So there's a lot to learn about how that process is going. So I'll just give you a few take-home thoughts, and then we can have some discussion if people want to. But again, Count Me In is just an example of this. But I think that what I think is that participant engagement is a really important component of all thoughtful research, that we get to learn from patients, and patients get to be included and empowered in the process if they want to. But it really requires a commitment to continuous feedback and learning. It's not a one-off. It's not a quick thing. It has to be back and forth all the time. It has potential to promote equity and improve representation of a diverse population, but that takes work and real thought. Core principles are power sharing and bidirectionality. Patients need to be valued as key members of the team. And, ultimately, the goal of this is focused on respect and value of each person, and all members of the team are equally important. So I'll stop there. I want to thank everybody for listening. And these are for people who want to go look at the website. These are our links. The first one is to the main page for Count Me In. The osteosarcoma project is below, and then the leiomyosarcoma project. And I think also, we can help, share these links further if that's helpful. But I'll stop sharing my slides, and then maybe we can have discussion. Thank you.
Thanks so much, Dr. Mack. And you were a trooper making it through all of that with, I don't with one sip of tea, like dealing with a cough. So we'll give you a moment to maybe do that. And I would love to hear, you actually had raised a great question, and I'd love to hear from Camille and Max about their experiences with participating in studies or trials. And that question of, have you learned results from any of the studies that you've participated in? Would either of you like to tackle that one?
Yeah, I can definitely tackle that one. So the first clinical trial I participated in was in 2015. It was a monoclonal antibodies clinical trial. I unfortunately had a grade 4 allergic reaction to that trial and was taken off. And I was never communicated the results. And you would think maybe that was in 2015. So what's that now, like 9 years ago at this point? That maybe they would have enough patient data to communicate results, but then again, with such a rare cancer like osteosarcoma, maybe they just don't have enough data points to communicate the results. But that's been my experience with it. And any of the other trials I've done, haven't heard anything, and it might be because they were too recent. And how I've found kind of results is from knowing a person in the community that was also on that trial, and we kind of communicate like, hey, like, did you progress on this trial, or how are things going? What were your symptoms? Stuff like that. That's kind of the main way I've personally found results, is communicating with other people that have been on the trial.
And can I ask, Camille, would you ideally want to know the results if you could? Or is it not a big deal?
I definitely would want to know, especially the trial that I wasn't able to participate in. I mean, I think I'm just curious, in general, like what are the innovations being made in osteosarcoma and how successful are these treatments, and can my participation, even though and especially in the one that I had the allergic reaction to, does that help future patients? And so I would want to know the results, but I understand not everyone does.
Yeah.
What about you, Max? Any
Yeah, so
studies you participated in?
yeah, I actually haven't ever participated in a clinical trial, but I think that if I were to, I'd really want to know like what's going on with what I'm giving. Like, is it useful? Are they even using the data that I'm sending, or is it like being like sampled out? And I think that being clear, like in the beginning, is really important because that also makes people less hesitant to send in information. Because if you're like, um, you'll get it within like 2 weeks. I think that's a really good way to make a trial seem like uh, the data that the patient's giving is really making an impact.
Mm.
And I definitely think like being translucent with that is important.
I'm curious, Camille and Max, have you guys ever donated, aside from participating in a study, just donated biosamples and ever gotten feedback on what happens to those?
I honestly can't remember. I think my mom is watching this, so text me, mom, if you remember. But I
Photo
know that I know that I've gotten my like tumor sequenced, but I don't know if it was specifically sent anywhere. So I know some of like my genetic mutations, or I don't remember them, but my team knows them.
Yeah.
Sam, I haven't ever donated any genetic. Maybe my parents know, but I mean, I'm not really in control of that stuff.
Yeah, I mean, I don't know. I don't know if there are any like kind of restrictions or privacy issues around this, but I do think it would be. I mean, I know from personal experience, like, we donated tissue and like we never know, like, did that result in a cell line or a PDX model? Like, I wouldn't mind knowing. And then I think kind of the other thing on just even finding out about results from a clinical trial, and I know the timeline can be very long for that. I mean, some of these studies recruit over years and then the
Yeah.
analysis takes years. But I think it would be kind of cool, like if you knew that, your sample was used in a study and paper was published, and then to kind of know that, oh, you were part of that. I mean, obviously they can't, it's not for public dissemination, but just personally it would be cool to know that you were part of the data driving that study and analysis in that study. I don't know if that's possible
Camille,
at all, or like,
I think your mom chimed in. I love it. And she says that they were able to develop a cell line, and it's at the
Yeah.
Broad.
that's so
Love it.
great. Yeah.
That's so cool.
Yeah.
I'm curious too, and it would be great too, Camille and Max, for you to chime on kind of what kind of resonates the most with you, but what you found, because I mean, you've obviously done pretty sophisticated kind of marketing communications around all of this, and I'm wondering kind of what you found in terms of the messaging that resonates the most with patients in terms of motivating them to want to participate. And I imagine that might change over, like, depending on where they are in their diagnosis and treatment timeline. But I'm wondering if you've kind of found if there is a specific message that resonates the most, whether that's kind of deriving some sort of personal benefit or whether it's just the empowerment message, planting a tree, and for shade for someone else in the future.
Yeah.
Oh, you can go, Max.
Uh, I was just gonna say that I was really it resonated with me with you when you mentioned that the research done today will be extremely important and guide the research that's being done for the people being diagnosed in 10 years. And I think that hearing that from people like you and from doctors will really resonate with people. Like it resonated with me today. And I think that that kind of mentality is like important for trying to recruit people.
Yeah, for me and my family, anything that we can do to um try and cause a cure for osteosarcoma, especially when frontline chemotherapy like MAP and MAP-IE failed for me, knowing that even if treatments might not work, like continuously, might not cure me, knowing that I am able to help scientists determine this might not be a good treatment or this is a good treatment, that is important to, creating a legacy and feeling like I'm, doing something worthwhile in a really tricky situation.
Yeah.
And Dr. Mack, how about like based on your experience and count me in, were there particular messages that you found kind of resonated the most with patients?
I mean, I think what I'm hearing from Max and Camille is really what motivates a lot of people. They just, well, it's like you say, they want to make it better. They want to make things better for people in the future, and they don't want anybody else to have to deal with what they had to deal with, and I think that the adolescent and young adult age group, what a compassionate, altruistic group. I think that, sometimes the wider world doesn't know that power that this group has of caring about other people. And but that's what I see is just this incredible generosity. And yes, we all hope it will help the patients themselves. But we also know that the most likely thing is that it's going to generate knowledge for tomorrow.
And Dr. Mack, do you see any differences between, and I don't know like the correct terminology, but like a clinical trial where I guess it's like a interventional study where someone's actually potentially getting access to an experimental therapy or something, versus a study like CalMe-In where you're not getting access to any sort of treatment, you're really just providing basically your data, your medical records, potentially some biosamples. Are there any differences, I guess, between those two different types of studies in terms of engaging patients?
Yeah, I mean, I think that people's perspectives on the two types of studies are often pretty different. I think so for treatment trials, a lot of times people are hoping for some benefit. They're hoping that they'll get access to something that's newer and better, that can help them. And sometimes we don't know if that direct benefit is possible. That's why we have to do the trial, to learn. But at the same time, even as a clinician, as a physician, that's part of my desire when I enroll patients in trials is that I can help them. But also those can be very hard decisions to make, because, especially if you have, like, say at the beginning of treatment, you might have something that's kind of like the standard of care, the tried and true, and then you might have something that is a little bit different. And people have to kind of weigh, do they want the thing that we know works but doesn't work as well as we want? Or do we want something that's more unknown that hopefully is better but might not be as good? And so those are really hard decisions to make and to weigh. And high stakes, maybe something really good could happen, but you just don't know. And then when it comes to these kind of biospecimens or the kind of testing that's done on samples, the stakes aren't quite as high, because it's like, oh, I've got leftover tissue. Somebody might as well learn something. That's often how it feels. But also sometimes it feels like maybe the potential benefits are not as huge as you might like also, that there's more of that feeling that it's really for future knowledge. And so I think those are the kinds of things I hear people weigh. And again, the goal is just how do you help people make the best decision for themselves? Because there's not one way to do things, but if you can find what's right for you, then we've done a good job.
I had a question. Having relapsed 8 times, we've been offered, or we've either sought out or been offered so many different clinical trials all across the country and different methodologies, perhaps as well, like CAR T cells, repurposed medications, chemo pills, immunotherapy. How can like patients and families kind of determine what the next best step is? And can genomics help in kind of determining what the best decision would be for patients?
Yeah, so sometimes genomics can help. The way that it can potentially help is that it can identify those genetic changes in the tumor that might be associated with response to a certain type of treatment. And so, it's many people don't have those kind of changes, right? So you might do that genomic testing and not really find the magic bullet, but sometimes we do. And so that's one of the reasons that we like to do it for our patients, because there is that chance that it could be helpful to them personally. And so oftentimes we do it because it might help. So that can help you sort through things. And then when it comes to like all these different trials, I think there are a few things that can help you. One, which often would come from your medical team, is what kind of makes sense? What do people feel good about as something that may be helpful? And sometimes they can help you sort through, like, this just seems like the right thing based on everything we know. It's the logical next step versus something that might feel more like a shot in the dark, and so that's always a gray area, but that is one thing that can help. I think other things that can help are kind of what's involved in the treatment and what is kind of right for you at that moment in time. Sometimes you have to relocate for a trial. Sometimes a trial involves a lot of time in the hospital or is going to have side effects that you're not excited about, whereas some may be more tolerated. I mean, if I could tell you what, if I said, oh, well, this one is definitely the best thing, you would say, oh, maybe I'll do whatever it takes, right? But if we're not sure and we have two equally good options, then maybe you want the one that allows you to be in school or not lose your hair, right? Or whatever it is that you're kind of hoping for at that moment. And that's okay, because if we don't know, then you should make decisions that are good for you, And if we do know, then we tell you. It's hard decisions for everybody.
I'm curious, Max and Camille, too, if you remember, and it might be hard because it might have been a while ago, but if you do remember, like, your oncologist presenting you with consent or just talking to you about participating in a trial or study, whether it was at that institution or different study at a different institution or something like a Count Me In. Do you remember having that conversation and just kind of thoughts on like kind of best way to approach patients on that?
I've definitely do you mean like being communicated like the consent and kind of like
Yes.
potential side effects? Yeah. So, I definitely remember being presented those. They can be a little wordy to understand, especially, when I was like 14, 15, 16, trying to read that 40-page consent, can be a little challenging. So I kind of relied on my mom to help, kind of get the main bullet points, and also my oncologist to kind of communicate what I needed to know about like side effects, you know any additional scans or like blood work that needed to be done. And also another thing that has been really great is if there's any like updates to the consent, they always present you with that. I think one of the trials I was on, there was some adverse event that happened for someone at one of the locations. So she just communicated that to me and I re-signed the consent and it was all good.
When I was going through treatment, I was only 10 years old. So at that time, I didn't need to give consent. My parents needed to give consent. So I'm pretty sure they probably were approached by my oncologist and stuff. But yeah, at that time, it was like really out of my hands. I expected if I was older, like past 18, that I'd have to put in more of the work. But at that time, like it was definitely different.
Yeah, I think it's kind of challenging, in a disease like this, because also, especially I guess for biosamples, it's important. You kind of want to try to get patients earlier, right? Like closer to diagnosis, in which case you're really dependent on the oncologist kind of communicating and education patients, because at that point, patients have no idea, right? They've just kind of been hit by a truck and just trying to figure out so many things. And I think part of the challenges are that there are different studies. There are like so many different studies for patients to enroll. There's Count Me In, but there's like Project Every Child, which is like a COG thing, and there's some various other things. Not to mention probably studies at that specific institution. So there kind of are. It's a challenge. There's a lot of competing interests in terms of there's a lot of options. And I know, as you mentioned, oncologists, last thing they want to do is just like overwhelm the patient at a time when they're already overwhelmed. So I don't know, just like thoughts. I think it's a tough problem, but just like strategies for creating awareness in that oncologist community and trying to breaking through, just knowing, and especially you said, majority of the patients are at these community hospitals, which are not necessarily these larger academic institutions where they are, more aware of some of these studies and trials going on. So I don't know, strategies for just kind of being able to break through that and create awareness in the oncologist community.
Yeah, we're still working on it. We have a working group that's focused on, how do we make oncologists aware of this? We have those little postcards that we send out to oncologists who treat patients with sarcomas, and try to have them keep them in their waiting rooms or keep a pile of them in their exam rooms so that they can give them out, and just try to make it easy for them because, but then I think for patients who are feeling overwhelmed at the beginning, just knowing that there are resources out there, people are trying to help with these things, sometimes can be helpful. And if they don't have the brain space to deal with it at that time, it's okay. They can send in samples later.
Great. Max, I think you had a question.
Yeah. I was just a little interested. I know you showed the graph of like the US. Were you hoping, or does the Count Me In project only focus on the US, or do you also collect samples from around the world? And I was also a little interested on like what efforts Count Me In is using to fill in more of those states. Like, are you approaching oncologists?
Yeah, great. Thank you. Yeah, so we right now we're able to work with the US and Canada, but our hope is to work things through to do this internationally. There are kind of like like laws that make it complicated to go beyond the US and Canada, and so we kind of have to figure out how to navigate that, which is more complicated. I'm not a lawyer, thank goodness, and and so I don't quite have the skills for that. But we have people on our team who are working on that. And then yes, we're working with oncologists in these areas. The other thing that we're doing is Christina mentioned Project Every Child, which is through the Children's Oncology Group. So we're working with Project Every Child to contact people all over who have osteosarcoma and who registered in Project Every Child. And so I hope that we'll be able to fill in some of those white spaces with that as well. Yeah, great questions.
Before we go, I just wanted to throw out one more question, which is just this whole, I think this whole, what you're doing is fantastic and really kind of empowering and engaging patients in this whole process. And this kind of like direct to consumer model where you're, really educating patients directly so they can come in and kind of ask about it, kind of, like whether in pharma or anything like that. There are some disease communities that have registries.
Yes.
And so can you just kind of talk about the difference between something like a Count Me In versus a patient registry?
Yeah. So registries are, they don't necessarily offer this kind of testing, but they have information. They collect information about diagnosis and stage and other characteristics of the patient and the tumor. And then that information is used, to understand things like kind of like the epidemiology of the disease, like who gets it, how old are they, where do they live, those kinds of things. And that's really important data. But it doesn't necessarily, so that's also providing data for research if you're part of a registry, and also just for standard care processes. But it doesn't necessarily offer this extra layer of testing in terms of the genetic or genomic information. And then there are some registries that also offer biobanking, where they will actually take your tumor or take a blood sample and store it, and then it can be used for future research. But most registries right now primarily collect that basic clinical data and then keep track of it. Yeah, it's a good question.
Thank you. Thank you for clarifying that. So thank you so much, Dr. Mack. We're already out of time, but appreciate your joining us on OsteoBites today and for making it better for pediatric and AYA cancer patients. More information on this and all OsteoBites can be found on the MIB Agents YouTube channel, on our website at mibagents.org, and at your favorite podcast place. And next Thursday, we will be joined by Dr. Mo Yang. He's an assistant professor and director of biostatistics and data science core in the School of Public Health at UT Southwestern, and he will join us on OsteoBites to discuss the Osteosarcoma Explorer, a data commons with clinical, genomic, protein, and tissue imaging data for osteosarcoma research. So kind of like, I guess, the back end of kind of Count means kind of getting in all the data, and this is kind of where some of that ends up. You can find our OsteoBites lineup for the next few months on our website, and if you have any ideas for future topics you'd like to hear about, please share them with us at events@mibagents.org. Thank you again, Dr. Mack, Camille, and Max, and for all of you for spending an hour with us today. And we hope to see you back here on OsteoBites next week when we chat with Dr. Yang about Osteosarcoma Explorer. Thank you, everyone.